Yes, so I am the first half of a double act. I'm going to start and finish. So I am a manager. I always preface these things by saying I'm not a clinician. But interestingly or not, I did start my life as a molecular geneticist in the 90s. And I actually mapped the human genome radioactively. That's just quite how old I know. They did move on to fluorescent sequencing, but yeah, I spent quite a lot of my time growing up yeast and doing polymerase chain reaction in another life in Great Ormond Street. Working on extremely vanishingly rare diseases you'll never have heard of. But anyway, so I'm going to do a little bit in terms of my career. I moved into research, out of research and into service improvement. So our network, which you probably haven't heard of either unless you work in stroke, is a service improvement network. So we work with the providers of stroke care and the voluntary sector and academics to try and improve services. So this is one of the projects we've been working on and working with Salford and particularly Dr. Sen in terms of how we can develop this new technology and then how we might be able to spread that across Greater Manchester and then potentially more widely. So I'm going to talk a bit about the nuts and bolts of how that happened. Dr. Sen's going to talk a little bit around what he did, the pilot and the clinical side of things. And then I'm just going to come back and finish off with the kind of so what. So I have a real problem as well saying cloppy doggerel, so I'm going to try and avoid saying it. Clopidogrel, cloppy doggerel. As Dr. Sen's going to talk about this in a bit more detail, but it is the drug is an antiplatelet medication that's given to people after a stroke to prevent another stroke. And there's an enzyme that's very important in its metabolism. And variations in this gene impair its activation, essentially. And as I said, Dr. Sen will talk about it. So if you've got a particular variant, then it reduces the efficacy. If it reduces the efficacy of the antiplatelet medication, you're more at risk of having a stroke. So effectively giving you a drug that's not going to work. The gene is very polymorphic. I don't know how many people here are geneticists or know about genetics. So there's 39 different variants of it. And some of them result in loss of function or reduced function. And these, importantly, particularly for Greater Manchester, these alleles are particularly more prevalent in ethnic minority populations. So in our region, we are disproportionately affected by our population are disproportionately affected by this. In terms of stroke, does anybody know anything about stroke? No, I didn't before I moved into stroke either. But people often know somebody has had a stroke. So in Manchester, we have around 3,500 of what we call an ischemic stroke. So that's a clot. The rest are about 900 strokes are hemorrhagic. But if you've had a clot, then you'll be offered antiplatelet medication. We also have about 5,000 patients diagnosed with TIA. Does anybody know what that means? She says, trying to make it more interactive. There you go. It's a transient ischemic attack. So it's what's known often called a warning sign. It's a mini stroke. So you have the symptoms, they resolve, but it's basically telling you that a big stroke might be coming. And that's our opportunity really, and preventing people from translating from a TIA into a stroke is definitely one of the main areas of prevention we need to be focusing on. So we have quite a lot of patients who have people that have a TIA. And so what we're wanting to do is use genetic testing to guide the selection of patients in terms of their antiplatelet medication. There is no point in giving people antiplatelets if they're not going to work. So NICE have been thinking about this, and I don't know how long it took them, but probably a long time. But in July 2024, they published some guidance recommending genotyping in stroke and TIA for when you're going to be using this drug. They talk about laboratory testing and particularly having a national service. But they also recommend point of care testing if lab testing is unavailable. At the moment, there is no commissioned lab service in the UK, and I'll come back to that sorry tale in a minute. So there has been a national pilot, which Salford was part of. The other sites involved lab testing. At the moment, they haven't published that result, and there's no timeline. I imagine because it's going to cost money. So everything at the moment with NHS England is a bit on hold. And so Salford trialled the gene drive system, which found that around a third of people did have loss of function alleles. I'm going to hand over now for the clinical bit. And Derry's going to talk about what happened.
Thank you. Just as a quick introduction, I'm Dwaipayan. I'm one of the consultants stroke medicine in Salford Royal, and I've got an interest in pharmacogenomic guidance in prescription and rare inherited diseases of the neurovascular domain. So I'm going to start just a couple of basic slides about the metabolism. So put it simply, clopidogrel is a prodrug. Once ingested from intestine, goes to the liver. This is where the CYP2C19 gene guides the cytochrome P450 enzymes to metabolize into active metabolite and inactive metabolites, and the active metabolites then goes and binds to the platelet via the P2Y12 receptors. And there are genomic variations both here in the CYP2C19 and the P2Y12 receptors. So CYP2C19 is a highly polymorphic gene located in chromosome 10, and it has 39 different haplotypes. And what they do, put simply, is there's a normal allele or a wild allele. So if you've got star 1, it means you've basically got a normal allele and you metabolize clopidogrel normally. But you also got a number of haplotypes which are either loss of function or gain of function. So it either inhibits metabolism or it makes metabolism go more rapidly. So these kind of star 2, star 3, star 4, star 8, these are the loss of function alleles. So if you have one of them with a normal allele, your metabolism is intermediate. If you've got two of them, you're a poor metabolizer. And then you've got star 17, which is a gain of function allele, so it makes your metabolism go more rapidly. It doesn't actually have any clinical relevance. So if you've got star 17 with a normal variant, you're basically a normal metabolizer. You metabolize clopidogrel. From a clinical perspective, it's still effective. So what does it mean then? The first guidance around antiplatelet prescription and interpretation of these alleles came in 2022 from Clinical Pharmacogenetic Implementation Consortium guidelines. Again, put simply, if you are a normal metabolizer or you're a rapid or ultra-rapid metabolizer, you just carry on with clopidogrel. If you're an intermediate metabolizer or a poor metabolizer, the guidance is to change to an alternate antiplatelet prescription. What I'm going to show is that the prevalence of this poor or intermediate metabolizer varies quite widely between ethnic populations. So there's a question about equity and access to healthcare when you're not doing this or doing this. And it's quite striking. So if you look at the Asian population, and this is quite consistent both in kind of epidemiological studies where you've just tested people and where you've done studies as of randomized control studies looking at alleles and genotype guided prescribing, you come to about 57% to 63% prevalence of poor metabolism of clopidogrel in the Far Eastern population. Drops down to about 45 to 50 in the Indian subcontinental population. And then you've got the African American, the Jewish populations, which is slightly more than the Caucasian and Hispanic populations, where you get about a quarter. But even there, it's not insignificant. It's about a quarter of the population that actually does not metabolize the drug. So from these kind of evidences, and there were studies, particularly point and point 2 in the Chinese population, they were kind of showing evidence that clopidogrel is not really working in these loss of function allele population. So using that, NICE came out with DG59 diagnostics guidance in 2024, which essentially mandated that every stroke or TIA or suspected stroke or TIA presenting at the front door should be tested for CYP2C19 status, and then the antiplatelets prescription should be guided by the genotype of the patient. So therein came the challenge. So, how do you implement in NHS as a diagnostic service what the NICE was recommending? So NHS England asked us to do a project. It was supported by the Network of Excellence in Pharmacogenomics and Health Innovation Manchester. And both MFT, Genomics unit, and Salford Royal's neuroscience unit were part of that. It's a 7-month project between October 2024 to May 2025. We were planning to test about 1,000 people, but the main thing was around feasibility and comparing lab testing versus point of care testing, and finding out, what's the pros and cons of using either approach to start a diagnostic service in NHS. So we had 4 sites, Doncaster, St. George's and Exeter were sending lab samples to the lab in Manchester. So there were a bit of logistics involved in terms of them taking the sample, posting it to Manchester, and so there was a bit of logistics involved in them taking a sample, sending it to the lab in Manchester, and the lab in Manchester then sending the result back. There's obviously a bit of delay in that. Salford is the only site that was using the point of care machine supported by GeneDrive. And the advantage of the point of care testing is obviously very quick results and very quick, therefore, amendment of antiplatelet prescriptions. A slide about the GeneDrive point of care system. It's a saliva test. It's very simple. It takes about 5 to 10 minutes to kind of sample and set up in the device, and it's very similar to how we used to do the COVID samples. So yeah, it's a fairly simple kind of COVID sampling kind of thing within 5 minutes into the machine, and it takes about an hour to a quarter past an hour to run the test. And at the moment, the GeneDrive system is actually testing more loss of function alleles than the lab testing that is available. That's not to say that the lab testing can be scaled up, but what is available now, the GeneDrive tests more loss of function alleles than the lab one. The concerns or challenges we had were scalability, whether there will be a lot of test failures and you have to kind of repeat your tests, and if we are testing at the front door where the diagnosis is not certain, are we going to have a loss of efficiency or wastage in terms of testing a lot of stroke mimics at the front door where the test is ultimately going to be irrelevant? So to tackle these, we kind of made a project plan. We wrote a SOP for that, and we divided it into broad categories like this, and kind of detailed that in SOP how we are going to tackle each of these, from testing to test results and who's going to action it and when, things like that. So the first bit, installation, the project was initiated in Salford in August 2024, but you can see that the testing started in March 2025. So there was a big delay in terms of both MFT's unit and Salford's point of care testing team both validating the point of care system against lab testing. So we only started after both hospitals or the teams in the hospitals were happy that that they've been validated twice against lab testing. It's fairly easy to set up. It's just a small machine, as you saw, and you just have to find a space to kind of plug it in somewhere, and need a space for keeping the samples, which are in room temperature. So there was no issue with that. And both GeneDrive and Salford's point of care team helped in terms of installation and training and quality checks on the machine. Staff training. So we took a cascade training approach. So we first trained 6 stroke specialist nurse assessors who were present 7 days in A&E, 12 hours, 8 a.m. to 8 p.m. So we covered that 12 hours of the day, seven days. Then we started training Band 3 healthcare assistants and HASU nurses. Our approach was outside those 12 hours, whoever's presenting at night gets admitted to the ward and then gets picked up next morning by the HASU nurses. And then later on, after a couple of months into the project, we started running a clinic by one of the academic clinical fellows who test the clinic patients. So we took a cascade approach by gradually increasing and scaling up testing. We kept inclusion-exclusion criteria fairly simple. So anybody who is suspected to have a stroke or TIA who's presenting to A&E, no contraindication to antithrombotic medication, not going to be anticoagulated, and a decent life expectancy, not severely frail, were included. Anybody who has a big bleeding risk, not going to be on antiplatelets, were excluded. Consenting was verbal, but we did develop a patient information leaflet. So we used to hand this out and then take a verbal consent, record that in the patient record, and then test. So I've already covered this. So anybody who was presenting to Salford with suspected stroke or TIA, if they're presenting during daytime, gets tested in the front door. We put 2 machines there and 1 machine in the ward. So anybody presented at night would get picked up next morning in the ward. So we kind of divided the machines into front door and HASU. Results were transcribed in the Salford's electronic patient record system. I believe there's a way for kind of direct integration from the machine into the patient record system, but because of the kind of short duration of the project, we didn't really go through that. The responsible consultant was made aware of the test almost immediately as the result came through, and antiplatelet prescriptions were changed on the day. We maintained a database, and the results were also available in the point of care machine itself as an audit trail for kind of looking back later if anything went wrong. So on to a few slides for test. The first thing we looked at is the test efficiency. So the total number of tests done were 586, out of which about 86% were fine. So just tested straight away, gave first one results on the first attempt. About 14% needed a retest. So there were no test failures. There was no patients that we didn't get an outcome. A few of them needed a second test. So this is the distribution of genotypes in a kind of typical GM population. So if you look at the kind of blue side, this is your normal metabolizer, rapid metabolizer, and ultra-rapid metabolizer, the kind of people who you think is going to, metabolize clopidogrel normally. And that comes to about 2/3 of the population. And about 1/3 of the population, intermediate metabolizer and poor metabolizer, are not responding to clopidogrel. Sorry. Right, so essentially it's just summarizing what we just saw. So if we summarize things, out of the GM population presenting with suspected strokes or TIAs, vascular events, about 2/3 are clopidogrel responders, about 1/3 do not respond to the drug at all. Amongst the non-responders, the vast majority is actually intermediate metabolizer and a smaller proportion of poor. Not that it really matters from a clinical context. This whole group is not going to respond. When we looked at the recurrent strokes, a similar pattern emerges. Again, about 70% are responders and about 29% do not quite respond. So 2 things to see. One is that clopidogrel metabolism do have a significant contribution towards recurrent vascular events. You can see that, but also from a clinical perspective, we need to be careful. So there's also a huge proportion of recurrent vascular events which have other reasons. So we shouldn't be always fixated on this only. So it's one of the major contributory factors, but not the not the only one. We did very well with actioning results. So the total number of results that needed actioning is about 190, which is the poor or the intermediate metabolizer. And we were able to change and action results on the same day in 84% of patients. In about 12%, there was no need to action it because the results turned out to be irrelevant because they didn't have a stroke or TIA, didn't need clopidogrel. So it's only about 4% patients that were missed, and they were picked up by the audit trail and were actioned later. And as I said before, there was always a little bit of concern about, huge waste and inefficiency by testing at the front door where your diagnosis is not confirmed. So we looked at the final diagnosis as well. And it seems around 10% of patients were being tested where it didn't really matter. So the vast majority actually had clinical relevance to testing. I've got a slide about the other lab sites that participated. So they together, the 3 sites, did 468 tests. And you can see, while I said that there was a bit of inefficiency, about 10% kind of, irrelevance in our kind of point of care testing because of front door testing, there's a bit of problem going on with lab testing as well, whether it was a sample problem or a mismatch problem, naming, et cetera, et cetera. They had a 9% kind of failure rate as well, where, the results were not available. The other point of interest is that the prevalence of poor and intermediate metabolizer over the 3 lab sites was slightly lower than the GM population. Now, whether that is because of the diversity of the GM population, or whether that is because the gene drive system is testing more loss of function alleles is, debatable. But both are, I think, plausible hypotheses why we see this slight difference of about 3 to 4% in the 2 populations. But this is the biggest advantage, I think, of the point of care system, where on average, the test took about 2 to 3 days to come back to clinicians. But when we did some qualitative kind of interviews for clinicians on either side, and what it came through is, well, it said 2 to 3 days. The actual process took much longer, because that will come back to the secretary, who would then give it to the consultant. The consultant will then write a letter to the GP, because you can see nearly 90% patients are by that time discharged already. Then the GP actions it. It's a long process. It's probably more than 2 weeks by the time that the thing gets actioned. Whereas if you look at our data, we were able to action approximately 90% of results within an hour of patient hitting A&E. So that, to me, is the biggest advantage of point of care system in a time critical situation like stroke. So before I pass it on to Sarah again, as a summary, we know that genotypic differences affect resistance to clopidogrel. We know that it affects clinical outcome. And what we know is that the prevalence amongst ethnic groups is quite widely varied. NICE currently recommends testing right at the front door for anybody who's presenting with stroke or TIA, not recurrent events, just before the first event, just before you give antiplatelets. They're suggesting that you do a genotype guided antiplatelet prescribing and not wait for a recurrent event. Point of care testing provides an effective and efficient way of testing. We have trialed and piloted it in NHS. It looks, feasible, scalable, deliverable. And we currently are using the gene drive point of care system in Salford. We are carrying on with the project at the moment, thanks to gene drive supporting that. And there's slightly more patients being found to have loss of function allele in GM compared to other kind of lab testing sites, although the reasoning behind that is not quite clear with the small cohort size that we have. Thank you. I'll pass it on to Sarah and we'll take questions at the end. Thank you.
Just going to finish up by just talking around what we're going to do with that. So obviously piloted at Salford. And in Greater Manchester, we operate what's called a centralised stroke model. So we have 8 stroke units, but only 3 of those accept patients for hyperacute stroke. So if you have a stroke, you're picked up by ambulance, you're taken to your closest hyperacute at Salford, which is open overnight, and then Fairfield or Stepping Hill. So not every region operates that model, but what it means is majority of people who have a stroke spend 3 days in one of 3 HASUs, and then are either repatriated back to their local hospital for inpatient rehab, or they go home. So our model means that point of care testing is critical, because most of our patients are discharged within 2 to 3 days or go to another hospital. The logistics, as Dewi mentioned, are a nightmare if you're trying to manage thousands of patients who've already gone home, writing to GPs. So our model is particularly lends itself to point of care testing. In terms of what we're proposing in terms of using these results, we're planning to have a 2-phase approach. So we would roll out in the 3 hyperacutes, because that means 3 sets of devices, etc., and 3 stroke teams. With the phase 2, we'd be extending that to our local stroke centres, who don't generally accept admissions, but all of those services do accept TIA patients. So that's what we're proposing. And we may, for the second phase, if lab testing is online, we would consider that, because for TIA patients and for district stroke centres, there isn't the same time critical factor that there is when patients are admitted to hyperacute stroke units. In terms of the impact, so we've looked at the data and we've estimated that it could save potentially 17 strokes a year. But that doesn't sound like a lot. I was expecting, I don't know what, I thought it was going to be hundreds or something. But when you think that every stroke costs about £45,000 in the first year and £25,000 thereafter, it's the single leading cause of disability in this country and is extremely expensive in terms of healthcare and also social care afterwards. But about 40% of people are left with some form of residual disability. So in terms of preventing stroke, even a small number of strokes actually has a huge impact kind of economically before you even consider the impact on obviously the patient and their carers. So there's a number of things we've looked at in terms of benefit for cost of a system. These are all sort of theoretical, but these are the sorts of cost health economics that you need to do to kind of stack up the argument. I think importantly for Greater Manchester, this is around health inequalities. We have a very ethnically diverse population. We are more impacted by patients who are likely to be resistant to a really important drug that they need after their stroke. So it's even more important that areas like ours have access to this testing. As I said, the point of care testing over lab testing provides a really good operational fit for our model. It works, and we've proven that it works really well and devices can be placed in ward areas, but they can also be placed in ED. So in terms of where we're up to, so we've done pilot, quite an extensive pilot, and I know that the testing is still happening at Salford. We've identified obviously a large number of patients proportionately are potentially need to have their therapy changed, and that there is potential benefit in terms of the health economics. In terms of what we've done next is we have actually taken that into a care board in terms of commissioning. You'll probably be aware this, so I'm just going to manage your expectations. This story does not have a great ending at the moment in terms of, it's still running at Salford, but the number of the issue is going to be cost. It's not free. We have to test potentially thousands of patients every year. And although there are benefits to that, it's going to cost the system in terms of new money. We don't do this at the moment. It's new. There's no way of shuffling the money around. This is a new innovation. And I think more widely, this is going to apply to things that are part of the digital left shift. Some of them, you can move money around, do things differently, but other things are new. They're innovations, and they're going to require investment. So I can say we've tested something, it's nice, approved, it works, but we don't have the funding to continue it as much as we like it. So I don't think I've got any more slides, and maybe that's the right place to leave it. Thank you.